So please join me in welcoming Dr. Rodrigues.
So maybe you can just put that, so that's there.
Just like that.
Great. So thank you so, this one, yeah. So thank you so much. So they said, I guess 30 or 35 minutes, so I generally have more slides than I actually can speak to, but when my time is up, you can say time out, okay? So the first thing is that, people always ask me, where the hell do you get a name like Brian Rodrigues? So, so I always like to give an introduction, and actually my parents are from Goa, which was a small Portuguese territory. And these Portuguese guys, they came and they converted everybody to being Catholic or Christian. And so my first name is Brian, which is my Christian name, and Rodrigues is probably because of some Portuguese wayward sailor having some fun in Goa. Anyway, it's a fantastic place, and if you ever have a chance, please visit it. It's absolutely terrific. It's white sandy beaches and blue water, and the people are really friendly like me. So if you ever have a chance, please go and visit Goa. Okay, so the other thing I like to introduce is because I staying in this beautiful place. How could you live in Vancouver and not fish? And so I do research, and my real life is actually this. This is actually fishing on the Harrison, and that's a spring salmon that I caught. And people always say that this thing out here is much bigger than this thing out here. But, and you can see why, right? So anyway, that's, these were catch and release spring salmons that we were releasing. And and I travel all over the world for fishing. So starting from Cozumel right up to Turks and Caicos, Jamaica, Cayman Islands, then from Antigua, Barbados, Trinidad, and then recently we just were fishing in Curacao. So like I said, I've had a wonderful opportunity to travel across the world. My job allows me to do that. So it's great that I actually have a life, and that's fishing. Okay, so sort of a little bit more topical. And in 2000, that was the incidence of diabetes. And you can see that by the year 2030, there's going to be a large number of people having diabetes. Now, this is not, because it's type 1 versus type 2, it's about 8 to 10% type 1 and 90% are type 2. But as you can see out here, this is a real big problem, and there's the tsunami coming up where there's going to be a large number of people who actually have both type 1 and type 2. And actually, it's made the news now. So in Newsweek and US News, etc., you can see diabetes, a growing health crisis, the diabetes epidemic. So there's a lot of awareness of this disease in globally across the world. And you can see that, it's basically a big problem. In Canada, we have about 9 million individuals who actually have diabetes. And we spend a large amount of money, almost $6.3 billion in 2000, and actually you can see almost doubled, $16.9 billion by the year 2020. So we take a lot of, it's really a burden on our healthcare dollars. And it's a growing health problem. So there are larger and larger number of people who have actually diabetes. Now, I know this audience is mostly type 1, but we have lots of young people actually who have type 2 diabetes. And it doesn't take a rocket scientist to figure out why, right? With this this obesity epidemic that we have, you can see that there is larger and larger number of people, young people, who actually have type 2 diabetes. Now, when it's for people who are just getting into the business. This is where we have this really neat organ which is called the pancreas. And within the pancreas actually is these cells called the islets of Langerhans. And it's in these cells called the beta cells that actually produce insulin. So with people who have type 1 diabetes, unfortunately, these beta cells, the cells that are actually responsible for producing insulin, these cells die. There's some different reasons why these cells die, but really, when you have type 1 diabetes, you have no beta cells. And because you have no beta cells, you have zero insulin. And because of that, you have to give yourself insulin exogenously. Now, these are the beta cells. It's kind of interesting that these are, as you can see in the pancreatic beta cells, in those islets of Langerhans, there are lots of these beta cells. And what happens with people who have type 2 diabetes, type 1 diabetes, is that because of some some mechanism that is not clearly understood, these cells, as you can see out here, they are basically destroyed, and you don't have any cells that actually make insulin. So that's type 1. For type 2, so as you can see out here, all of these beta cells basically die. Really, nobody knows why. They think we have a genetic predisposition, and really nobody knows what's this precipitating factor. Is it the flu virus? Is it cow's milk? Is it some toxins in the environment? As you can see out here, lots of research going on into why do these beta cells die. But really, as you can see out here, over time, maybe 1 to 3 years, you have a complete and absolute destruction, as you can see out here, of the beta cell. So in response to the destruction of the beta cells, you can see you have no beta cells, you have zero insulin, and you become type 1 diabetic. And as you can see out here, this was the original patients that were treated with insulin. These were Banting and Best. It was actually, insulin was discovered in the University of Toronto. This was a type 1 diabetic patient. Most people died because they didn't discover insulin at that time. And you can see the dramatic recovery of that same patient given insulin. You can see that insulin was a beautiful tool to basically cause the resurrection really of these patients who had type 1 diabetes. For type 2, it's a little bit more complex. For type 2, what happens is that you have lots of insulin, but the insulin is not working well. And that can also happen in type 1 diabetic patients. So I use this example, right? So you have lots of insulin. Insulin comes, binds to its receptor, opens the door, and all the glucose goes into the cell. So with type 1, you just don't have any insulin, or you don't have any key. With type 2 diabetics, you have lots of insulin, but the insulin doesn't work. The key doesn't fit. And so because the key doesn't fit, all of the glucose that's present outside cannot go into the cell, and you have hyperglycemia. So the difference between type 1 and type 2 is type 1 has no insulin, whereas in type 2 you have insulin resistance. You are incapable of using the insulin that your body is producing. Why do we become insulin resistant? Because of this. So you become obese, and now this can happen also with type 1. You become obese, and because you become obese, especially the abdominal obesity, what happens with the abdominal obesity is that abdominal obesity actually impairs the action of insulin, and that makes you insulin resistant. Obviously, the next question is, why do we become, why does this happen? Really interesting that all of that fat tissue that's present out here basically makes some toxins or poisons. And what happens is that those toxins and poisons that are released from the fat tissue, what it does is that it prevents your brain control of appetite, so you eat more. It also basically causes insulin resistance, so it prevents the glucose from going into the muscle. It prevents the liver. It makes the liver produce more glucose. And so really when we talk about being fat, as you can see out here, or abdominal obesity, that basically causes insulin to not work well, and you become hyperglycemic. Things to remember about obesity, and also with type 1, is this obsession with food. I think our North American society is so obsessed with, and especially not only food, it's in terms of volume. We have big plates, we have supersized meals, etc. And that basically is one reason why we become obese. Of course, the other thing is also we don't eat well. And this is a terrific example of something. If you can ever do something, do not drink pop. I think the pop is like completely disgusting. Like nobody should ever. We should ban pop really, because it's because of the pop that has fructose. It's the fructose in the pop that actually makes you insulin resistant. And it's kind of interesting that in 1950s, they actually used to have these advertisements that actually, advertise that pop is really good. And it says here, see, that proven that babies who start drinking soda have a higher chance of fitting in. I mean, this is in 1950s. Can you believe that? They would actually propose that you should actually drink pop because it would make you and other sugary carbonated beverages for a lifetime of guaranteed happiness. I mean, it's amazing. So it's not only that we eat too much, it's also we're eating the wrong type of stuff, especially with things like high fructose. And of course, the other thing is that we don't exercise. How many times do you see that where you have an escalator versus the steps and everybody's climbing onto the escalator, right? So, something about eating right and also eating the right proportions and also exercising is a very important message also for this group of people. Now, so we have type 1 and type 2, right? So with type 1, you got to do this 4 to 5 times a day. Take your Lancet, get your glucose, put it on a glucometer, and then in response to the amount of glucose that you have, you give yourself the appropriate amount of insulin, right? So you inject yourself insulin, 4 to 5 times a day, or you have a pump, for example. Now, for type 2, it's a little bit interesting because you obviously have to have diet and exercise, which is also prevalent for type 1, obviously. And of course, like I said, it's so difficult for people to maintain this regimen, both for type 1 and type 2. So, you got to do insulin injections and you got to measure your plasma glucose. With type 2, you got to diet and exercise and you got to eat well. Because of that, because of issues related to compliance, people with type 1 and type 2 have the complications associated with inappropriate glucose control. So some of the complications associated with diabetes are you have retinopathy, you have renal disease, you can have neuropathy, so you lose sensation in your fingers and toes and you touch something warm and you may have damage and leading to gangrene. And then, of course, my research, which is why do people actually who have type 1 and type 2 diabetes have heart disease? And so this is the big problem with people who have diabetes simply because of this inappropriate management of their plasma glucose. So, good glucose control is absolutely fantastic to prevent these complications related to diabetes. And in my case, I'll speak to mostly heart disease. Now, it's very interesting. If you look at the, with the discovery of insulin, as people started getting treated with insulin, you hardly ever have diabetic coma. So you hardly ever have this diabetic ketoacidosis, very high lipids in your blood that causes you to faint or, to get a diabetic coma. So you can see with the treatment with insulin, you hardly ever get diabetic coma. But look at that. Even though you're treated with insulin, as you can see out here, you still have this cardiorenal vascular disease. So the point is that even though you could be treating yourself with diabetes, you could be giving insulin, you're still exposed to the development of this cardiac disease. So, that's simply the point. The point here being is that if you have good glucose control, then you can actually reduce this cardiorenal vascular disease to out here. And I think that's the message that I'm trying to bring out, that fantastic glucose control will be able to have a significant impact in reducing the incidence of this cardiorenal vascular disease. Just to show you, this is the coronary artery disease. See that? Here's a control. Here's people who are type 2. This is within 7 years of follow-up. You can see that people who have type 1 diabetes, even though they are being treated with insulin, within 7 years of diagnosis, they already start to show heart disease. Now, if you keep yourself for a longer period of time, both type 2 and type 1 diabetics now start to show incidences of coronary artery disease. So the point is that, again, the messaging is that, type 2 is not so severe. Whereas type 2, because it's so, you don't have any insulin at all, you can see that within 7 years of diagnosis, if you're not treating yourself well, then you have a chance of developing heart disease. And definitely, the longer you have type 1 and type 2 diabetes, you can see that, the incidences of these complications go up. Now, you can look at it the other way too. So here's your control, and here's your patient who have diabetes. You can see if you have no risk factors, then you have a higher chance of developing heart disease. If you have one risk factor now, for example, if you have diabetes and hypertension, it goes up even more. Suppose you have two risk factors. Suppose you have diabetes, hypertension, and high lipids, then it goes up even more. And if you have three risk factors, for example, if you have diabetes, hypertension, high lipids, and you smoke, then the incidence is even higher. So the point is that simply having diabetes, you are at a risk of developing heart disease, and then depending on the risk factors that you have an even greater chance. So if you smoke, cut it out, right? Because if you your incidences of having heart disease are going to be even greater. Now, in the last kind of 10 minutes maybe, I'll simply talk about why do people actually who have diabetes have heart disease. So if you look at the heart, here's something called the coronary blood vessels. So, just to kind of to make it very simple, what happens with these coronary blood vessels is that these coronary blood vessels are the blood vessels that supply the heart with oxygen. With people who are diabetic, they have a higher chance of having a blockage of those coronary blood vessels. So because of you smoke, or because you eat inappropriately, or because you don't exercise, or because you have one of the risk factors, some of these blood vessels, as you can see out here, they get blocked. Now what happens is that if these blood vessels in your heart get blocked, as you can see out here, it's called atherosclerosis, the blocking of your blood vessels in your heart. Basically what happens when that happens is that this is your normal blood vessel. I hope this is what my blood vessel looks like, a nice, beautiful, open blood vessel. And this is what that same blood vessel when it has atherosclerosis. As you can see out here, nice, beautiful blood vessel. And then once you have this atherosclerosis, can you see that? All of that blood vessel is blocked. The opening is just out here. So the persons who have diabetes have a higher chance of getting a blocked blood vessel, as you can see out here. And because of this blocked blood vessel, as you can see, because of this lipid deposition, what happens is that once this a blood vessel gets blocked, now there are a whole bunch of complications. Now, if you look at the blood vessel out here, you can see that because of this lipids and because all sorts of things related to lack of exercise and high lipids and high blood pressure, etc., because it causes so much of pressure on these single cells out here, it basically ruptures because there's so much of pressure in your blood vessels. As you can see out here, it ruptures. So, anytime you get a cut, you have a scab and, a clot that's formed. Imagine now a clot that's forming inside your heart. So what happens is that if this ruptures and a clot is formed, that closes this blood vessel even more. And when this blood vessel is closed, now imagine that's the heart, these are the coronary blood vessels. Here's your atherosclerosis and clot that's formed. Anytime that's formed out here, now you can see there's no blood supply down into this tissue. The tissues do not get oxygen, and unfortunately, the tissues die. So the point I'm trying to make is that anytime you have blockage of your coronary blood vessels and you have a clot that's formed inside your blood vessel, basically what happens is that all of that tissue basically starts to die and you have a myocardial infarction. So, it's important that if you're diabetic, you have good glucose control. You can prevent some of the complications associated with diabetes by preventing, as you can see out here, this blocking of the coronary blood vessel and preventing this heart disease from occurring, right? So that's just the mechanism. So how do you deal with it? Right? So because it's something about, I always talk to my students about hope, right? And so it's not all doom and gloom. This is just what happens, right? You just have to take it, for what it is. Now, what do you do to prevent this blocking of your coronary blood vessels from happening? So you want to prevent this atherosclerosis, you want to prevent this thrombosis from being formed, you want to prevent this damage of all of the downstream cardiac tissue that is going to take place when these blood vessels are blocked. So first thing, physical activity. try to at least greater than 150 minutes of aerobic exercise. Now, this is for both type 1 and type 2. It just makes, anytime you exercise, you're just making that insulin work better. So, sometimes people, so if you exercise, you actually have to reduce the amount of insulin that you give. So the point with aerobic, 150 minutes of aerobic exercise is that this insulin, as you can see, the exercise acts like the WD-40. It just makes the insulin work better. And if it makes it work better, as you can see, you give yourself less insulin, you prevent hyperinsulinemia, which is its own problems. Okay, so exercise makes your insulin work better. If you can do anything, please exercise. Number 1, healthy diet and weight control. Right? Remember, I said that anytime you have obesity, because type 1s can also gain weight, and in fact, because they gain weight sometimes, especially young women, they stop taking the insulin. Don't do that. So, like I said, remember that a lot of the fat releases these toxins that actually make your insulin work ineffective. So weight loss and eating well is important. So try to prevent this hazardous waste from developing. Okay, so weight is very important. Glucose control. Try to get your hemoglobin A1C, which you probably already know, to 7% or lower. So you got to have good long-term glucose control. Hemoglobin A1C is simply a measure of the long-term glucose control. So what happens with glucose? It goes and binds to your hemoglobin, and because it's an irreversible reaction, and because your blood cells are living for about 120 days, hemoglobin A1C is a good measure of your long-term glucose control. So if there's anything that you should try to aim for your hemoglobin A1C that is less than 7%. And then, of course, now if you do have, unfortunately, develop, then you have to use the right tools pharmaceutically. So if you do have issues related to heart disease, I use this slide simply because it tells you the glucose control. See that? Anytime you have a meal, a breakfast, lunch, and an evening meal, the moment your blood glucose goes up, there's an immediate response and insulin is secreted. Now, if you have type 1 diabetes, you don't have any beta cells. So in this case, you have high blood glucose in response to your meal, but because your insulin cannot be released, you have to give yourself exogenous insulin to bring this glucose levels down. So that's the immediate response. You want to bring your blood glucose levels down immediately after your particular meals. But you also have to give yourself background insulin or basal insulins. Why? Because during, when you sleep, you still need, your brain still needs glucose, so you have lots of glucose coming out from your liver. So what you need to do is you need to give slow-acting or basal insulins. So the trick about type 1 diabetes is to have this balance between giving the right amount of fast-acting or rapid-acting insulin to bring these levels of glucose down immediately, and background or basal insulins that prevent the glucose from being released from the liver when you are not eating, especially, for example, when you're sleeping. So that's the issue related to insulin. So you got to really understand your insulins. Talk to your pharmacists and people like myself who understand insulins completely. So try to use the right amount of rapid-acting, short-acting, intermediate-acting, long-acting, and all sorts of pre-mixed insulin. So understanding your insulins is very important. I just want to make just to spend maybe a minute on insulins, just to make sure you understand about insulins. So anytime you give insulin, especially when you take basal insulins, now imagine that that's your skin, and you're injecting insulin out here. Anytime you inject insulin, the long-acting insulins are ones that stay together, bound very tightly. So it takes a long time for these long-acting insulins to dissociate and then eventually get into the bloodstream, then to show its action. So the long-acting insulins or the basal insulins are ones that basically are released very slowly from the site of injection. Whereas the rapid-acting insulins, they get to your bloodstream immediately. So the rapid-acting insulins, for example, they don't form these depots. They get, the moment you inject them, they go bam, right away. From the site of injection, they go immediately into the bloodstream and they show the action. So it's very important that to get a good hemoglobin A1C, you have a complete understanding of not only your fast or rapid-acting insulins, but also your basal insulins, because you need to have very good glucose control for 24 hours. So understanding both your rapid-acting and your fast-acting insulins, I think, will give you a, you'll be really on a winning note, because you'll have very good control of your hemoglobin A1C. If you have, and then maybe in the last 2 minutes, that's just treating with insulin. If you do have high lipids, because people who have diabetes also have high lipids, you'll probably hear of things like bad lipids, like the bad cholesterol called LDL and the good cholesterol like HDL. So if you want to protect your heart, because remember, we're only talking about the heart here, then you want to give drugs in addition to insulin, drugs that can lower your bad cholesterol. So you'll see people, and very often when you talk about LDL cholesterol, you must always try to get your LDL cholesterol to less than 2 millimolar. So it's not only about glucose control. And that's the point I'm trying to make, that when you are diabetic and you do have high cholesterol, you must make sure that you not only aggressively treat your high glucose, you also want to treat lipids. So how do you get your glucose control less than 2 millimolar in terms of LDL? There's a whole bunch of drugs called statins. These are very commonly used drugs for the treatment of high cholesterol, especially again in patients with with diabetes. Okay, so a number of drugs called statins, a whole bunch of drugs that basically can lower that bad cholesterol. If your blood pressure is high, like the Mona Lisa, you should always keep your blood pressure between 120 and 180. Remember, that's a risk factor. So you want to keep your blood pressure low. Not only get your blood glucose low, not only get your lipids low, you also want to be like Mona Lisa and have a smile on your face by trying to get your blood pressure to about 120 to 80. And to do that, you always want to keep your blood pressure less than 130. And in this case, the drugs that are used to treat blood pressure are called the prills. So there are a number of drugs that are used to treat your blood pressure. And in that case, as you can see out here, there are a whole bunch of drugs. You contact your physician if you have high blood pressure, and the prills are very commonly used. And then finally, you'll see patients who have heart disease during diabetes. They give them low-dose aspirin. And basically what low-dose aspirin does is that, remember I told you when your blood vessels are closing, you can see that such a pressure is caused that it causes this damage to the endothelial cell, as you can see out here, and you have the blood clot that's formed. What aspirin does is aspirin prevents those clots from forming. By preventing these clots from forming, as you can see out here, they prevent the blockage of your blood vessel. So you use a treatment of high glucose, you treat treatment of lipids, you have treatment of your blood pressure, and you have things like low-dose aspirin that basically prevents the clots from forming. So, and the worst case scenario, if you do have a blockage of coronary blood vessels, then there are two techniques that we use. One is called the coronary bypass. See that? Here's your blood vessel that's blocked. So what they do is they take a saphenous vein from here, right? Or they take a vein from here, and what they do is as you can see, they just bypass that damaged area. So they take these veins and they simply bypass it, and they take that so that now all of this tissue out here can be perfused. So simply using a coronary bypass, you can basically prevent that damage from occurring. Or what they do is they put balloons into these blocked vessels, see that? And by just putting these balloons and inflating them, they can open the blood vessel. Or what they do is they put metal struts inside. So they put a stent into your blood vessel that simply opens your blood vessel and basically allows all of your heart to be perfused with oxygen. So I think that's kind of, I could have spoken for another 1 hour, but I thought I'll say thank you. That's like my heart only deeper. And I guess I don't have any time for questions. I can during the lunchtime, but thank you so much.
So please join me in welcoming Margaret. Oh yes, go for it, yes.
Yeah. So you guys know what that's like. For me, what happens is my brain starts to get a little foggy. And sometimes I can feel my heart start to pound harder. And I start to sweat. That happen to any of you? Yeah. And one of the things that I've realized and learned when my blood sugar starts to go down is that I also have some anxiety because it's frightening. And I wonder sort of what's going to happen to me. And there's a reason that I have those fears. So let me take you back. Come on with me. So it was 1966, and I was 1 year old. I'm a little bit older than many of you. And my dad was 26, and he and my mother had been married for 2 years. And it was in rural Minnesota where they like hockey. And he was starting to lose weight. And he was really thirsty all the time. And so finally my mom encouraged him to get himself to the doctor. And like most of us in this room, he was told that he had type 1 diabetes. And that was a rough thing for someone like my dad, as it's difficult for us. And what happened is my dad kind of took this path of not really telling anyone that he had diabetes, because he blended in, which we can do. People don't necessarily know that we deal with diabetes. And it was kind of his philosophy that he wasn't going to actually tell. And the thing that happened is that my dad had been a very competitive athlete in high school. He got a 4-year scholarship playing basketball to college, and he was a runner and a cyclist. And he didn't stop doing those things when he was a father and a husband. So he kept doing those. Now the thing is, I don't know if you know about this, but when you have a lot of low blood sugars, what happens is that your body becomes less sensitive to the hormones that indicate to your body that your blood sugar is going down. So the epinephrine and the, what's the other one? The other hormones that tell you, the cortisol. Yeah, so your body becomes less attuned to the warnings that your blood sugar is going down. And my dad became hypoglycemic unaware. And my dad's really tall. He's 6'4", which I'm not sure. Do you guys use that? Yeah. Okay. Well, you know, I'm trying to keep track of the differences. So he's a big guy. And for him, because he was hypoglycemic unaware, his blood sugar would go crashing down, and we wouldn't know that it was happening. My family was pretty adventurous. So what happened is that at least once a year, and this is through my entire childhood, the paramedics came to our house or to our campground, because we went camping a lot. And I still remember one of the instances when the paramedics showed up at our campground, and I have a younger brother and a younger sister, and I remember holding their hands and wondering if my dad was going to die this time. And those of you who are type 3s, you know that feeling of, is this going to be the time that this person might not make it? And that visceral fear of what low blood sugar could do to me, or could do to anyone who was having that, was deeply ingrained in my whole body. So then, moving forward a little bit, when I was 16, 1 month after I turned 16, I started to lose weight, and for no apparent reason, because I felt like I was eating all the time, and I started to eat all the time. And because my parents recognized the symbols, and oh yeah, by the way, how many of you have had diabetes longer than 30 years? Let's give it up for these folks. So when my dad was diagnosed way back then, it was what I like to sharpened his needle with a wetting stone, and he boiled his glass syringes, you know what I'm talking about, on the stove. It was like there was this little science experiment area of our kitchen. And his abdomen and his legs were literally bruised because those needles were so big. And it was well before any blood sugar testing. So the only real tool you had to tell if the beef or pork insulin, because there wasn't the synthetic insulins we have now, was working, was testing your urine and seeing what your glucose level was in your urine, which would tell you 4 hours later how you were doing. And so we had those test strips, and my dad said, here's one of these test strips, and go pee on this. And sure enough, it turned the darkest green that it could turn. And so my parents took a deep breath, and they said, well, we'll go to the doctor tomorrow. I still think of that. It's like, really? So we did the next day, go to the doctor, and I didn't have to be hospitalized because my blood sugar was only 350, which for a type 1, that's pretty early. And so, sure enough, I had diabetes. And I took 2 approaches because I was 16 and I was a typical rebellious teenager. And the first thing that I did is I did the exact opposite of my father, which children often do. Parents, they do grow out of that. And what I did is I talked about diabetes with everyone, all the time. I became a walking encyclopedia about what was happening in my body because I wanted everybody to understand. And my dad, at first he was very hesitant about that, but the other thing that did happen is when I was diagnosed, I walked into the TV room and I realized it was the first time I'd ever seen my father cry. And he just had tears streaming down his face because to see his daughter have what he had been dealing with was incredibly difficult for him. So he understood that I was a rebellious teenager and that talking about diabetes all the time was my way of dealing with what had happened to me. And then the second thing that I did is I decided that I never wanted to put the people who were around me through what my father had put us through. So, and this wasn't a conscious thought, is I ran my blood sugars too high. And I purposefully didn't exercise because I had watched that the majority of my father's circumstances were when the paramedics came were related to his athletic endeavors. And so I made that association that if I exercised, I would create what had happened to the people around me. So life went on, and I went to college, and I became a high school Spanish teacher, and then I went to graduate school, and I became a high school principal at age 29. I was a high achiever. And then I turned 30. And this is right around the time that A1C tests became more common. And I went to the endocrinologist, and she said, your A1C is 12.8. You are on the fast track to dying and very bad diabetes complications. And I looked at her, and I said, thank you very much. And I walked out of her office, and I essentially had a choice. I could continue doing what I was doing, or I could make a change. I tend to be a person of action, so I made some changes. And the first one I made is I fired that endocrinologist. And I found a different one who was much more collaborative with me. And she got me on an insulin pump, which was amazing. And this was back in 1995, so I was an early user of an insulin pump. And then the second thing I did is I applied some of the things that I had been teaching my students in high school, which was to take charge of your environment. And I started a notebook. I still have the notebook, and it says Mari's Wellness Guide. And I kept all of my records in it. I started keeping records again. And I wrote down everything that I was learning as I was learning it. And then the third thing I did, and this one I had to take a deep breath, is I decided that the thing I wasn't doing was exercising. So what I did is I hired a personal fitness trainer, and I still remember the day I walked into her studio and I said, all right, I have diabetes. And I stared at her. And she's like, okay, that's fine. And I was like, all right, this could work out. And she agreed that it was okay with her if I tested my blood sugar as often as I needed to. Sometimes that was every 10 minutes. And the reason is because I didn't recognize in my body the difference between my blood sugar going down or just simple physical exertion. And I also have low blood pressure. So sometimes doing those exercises would lower my blood pressure, not my blood sugar. And I couldn't tell the difference. And this was well before CGMs. I mean, I got the whole 9 yards going on these days. I'm growing up technology. And it was well before that. So I couldn't figure out, and see, early on I didn't understand how insulin worked. So I didn't know sometimes I would go to work out and I would have just taken a bolus. Well, that wasn't such a smart idea now that I know that. And I would be crashing, and like I said, I couldn't tell the difference. So I had to learn the difference between all these different things. And she was very patient with me. She's like, do you want to test again? And I'd say, no, I think I'm okay now. So I kind of went on for a while like that. And then about the time I turned 35, and this is the romance section of my talk, I met a guy who is paraplegic. And he had jumped off a cliff when he was 23 and broke his back. And he moved to California to live with me. And within a few months of meeting him, he decided that he wanted to become a competitive cyclist. So he ordered a hand cycle, and he decided that he wanted to draft off of someone, so which means you cycle in front of them, two cyclists, and the person who's behind gets a little bit easier ride based on the person in front of them. And he decided he wanted to draft off of me. So I was like, all right, we'll go riding. And he would ride behind me just close enough, and he would yell at me the entire time. And this is what he would yell. He'd say, perfect circles, come on, keep pedaling, And I still know how to pedal nonstop for hours and hours on end because Chris would be behind me. Now the other thing that's really cool about Chris is that he had no problem being with me as my blood sugars would go high or go low or be okay. And he would stop with me when I needed to test. And he would ask me 3 questions every time I took a blood glucose test. And the first one is, why is this happening? And at first I was like, I don't know. And he would help me kind of figure out, why was this happening? And then the second question is, what can you do about it right now? So if I needed to eat, if I needed to take an bolus, whatever it was. And then the third question he would ask is, what can you learn from this? And he would encourage me in my journal to write down what I could learn. And so one of the things that was pretty incredible about Chris is that he focused on what he could control versus what he couldn't control, which is a really valuable thing to learn early on. And a little aside about Chris, he's actually Canadian, and he switched sports from cycling to cross-country sit skiing, and he just won a gold medal in Sochi. And he just always focused back on what was actually in his control. And so one of the things that happened is shortly after we started riding, like 6 weeks after we started riding, he decided he wanted to compete against other hand cyclists. And he found the whole race calendar in California. And we drove all over California to all these bike racing events. And there were all these amputees and paralyzed guys and gals. And this is where perspective really, really helps us. kilometers a day. So what I did, and this I learned from Chris being a competitive athlete, is I found an endocrinologist and I found a cycling coach, and I forced them to talk to each other as they talked to me. And because of that, when I did this week-long ride in Colorado, my blood sugars for the entire week, and I trained with both these two people helping me for many, many weeks, because I'm kind of a control freak and I like to plan, is my blood sugars stayed between 4.4 and 8.3. Not bad, huh? I know. Yeah. And I was on that bike ride, and something happened inside of me that was incredibly transformative. And what that was is I realized that there was an inner athlete inside of me. And I claimed the title athlete. And this is at age 39. I mean, I was not athletic as a kid. And I realized that it's never too late to take on that title. You know, you said 150 minutes of exercise a week. And I was like, you know what? I can do this. And it was learning and seeing myself as an athlete. And there were a few key things that I noticed that Chris did, and this Chris, who's an Olympic athlete, you can see her. And this is what athletes do, is they pay attention to what they eat. They pay attention to how much stress is in their life. They pay attention to how much sleep they're getting. And all of those things, it turns out, helps my diabetes. And one of the other things that really good athletes do is they get the information from their coaches for how to perform better. And so finding endocrinologists and diabetes educators and nutritionists who can teach you the things you need to learn to be even more effective with the condition or the situation that you have was a huge, huge transformation for me. And the other thing that's really helpful about being, in a community of people who have diabetes is the ability to talk to one another as you're figuring things out. Because one of the things you all know is that a lot of what diabetes is about is trial and error. What works, what doesn't work, and keeping logs that help you sort of sort that out for yourself, and figuring out what else do you need to ask. What other questions do you have? And one of the things that I realized from claiming the title of athlete and doing that bike ride across the state of Colorado is that I could handle as an athlete whatever life would throw at me. And it turns out that life threw at me cancer twice, which I wouldn't have made it through cancer if it hadn't have been for thinking of myself as an athlete. And I rode my bike to chemotherapy a couple times, which turns out that's really hard. And I rode my bike over half the time to radiation therapy, and a bunch of my friends would come and ride with me. And I did my first triathlon a week after I finished radiation therapy. And I was like, all right. And then what also happened in the US is that you can do events as a cancer surviving athlete and get recognition. And that's what happened. And then I went and did a bike ride for diabetes, which I had done many of them. I've done probably over 10 of them. And I never knew who had diabetes. And because I'm a loudmouth and I talk a lot, I would ride up to people and I would say, do you have diabetes? Do you have diabetes? And sometimes they'd say yes, but I couldn't tell who had diabetes. The way I could tell at the cancer surviving events, because I got, a t-shirt that said Team Survivor. And I was like, we have to show the world who we are. We have to dare to stand up and publicly tell our stories and publicly show who we are and how we live and what happens in our heads when we're figuring out how many carbs are we eating, how much insulin do I need, when's the next time I have to test my blood sugar. Because if we don't explain it to the world, they can't know who we are. So that's why I started the Red Riders in the US. So now there are 7,000 people who U.S. and do a tour with us, you can. And across the back it says, "I ride with diabetes." And the exclamation point means I love you, because I like exclamation points. And as you're riding, and in a tour here, everybody yells to you, "Go Red Rider," because we need that love and that celebration for what it takes to live well. So grab one of these cards, because I have a little assignment, because I was a teacher and a principal. So grab one of these cards, they're in the center of your table. And the question I have for you today, because you're here in this room with all of these wise people, the question is, what do I want to learn and understand better about diabetes? And I'd like you to take a moment and jot down your question. What do you want to learn and know from being here today? I don't know if you all have cards. Maybe you're just thinking of your questions. But you guys are so advanced. You just have your question in your head. But you can use that as lunchtime. And the last thing that I want to be sure to have you all do, because this community that we create, and what was so powerful, and why I love doing tours, I'm training again. The second time I had cancer was almost 4 years ago. I haven't done a big athletic event since before the second cancer. So I've decided, and I'm training, and I'm deep into it. Last week I had to ride my bike 12 hours. I'm training for a 100-mile bike ride at the end of June. And this room, full of amazing people, we all have possible answers for your question. So in order to have enough sort of courage to ask those questions, you got to actually connect with the people around you. So before you go back and get lunch, what I want you to be sure to do is to give at least 3 people a high five. And as you look them in the eye, and just mentally say to that person, "You are so cool." All right, so let's give it. There you go. So that's how you do it. So be sure you hear. Yeah, let's do it. I love it. So thank you very much. And have a wonderful day.
So please join me in welcoming Tony Cervati. But you can.
The endurance cyclist sits all the way in the back of the room. It takes so long to get to the front. I was listening to the other speakers earlier today. There is a common theme for people who've had diabetes a long time. And I did want to mention, I'm a firm believer in always looking at the positive in everything. So I was listening to Dr. Rodrigues earlier, and I don't know if you know this, but anybody with type 1, you're immune to the zombie apocalypse, because zombies can smell beta cells. So that's something that we talked about, so that's positive. And I was also giggling when Mario was talking about the diastix they were called for urine testing. That's what I had too when I was growing up, and it turned out that we found out later in life that I had a blue-green deficiency, so I'm partly colorblind. So, you know, totally ruined it completely. So that's positive.
That's not bad next to race, you know?
No, but that's actually a true story. So it's like a joke in my house. My clothes match, right? So my name is Ruddy, like I said, I'm from the States. I flew in yesterday from North Carolina. It was an endurance event just to get here, like so many other speakers had. And as mentioned, I was diagnosed 38 years ago. Same traditional story as a fair number of you. Started wetting the bed again and drinking all the time. I was 8 years old. I was in the 3rd grade. And one of the unusual things about my diagnosis was I was at the hospital and I heard somebody at the back table talking about injecting oranges, and we need to do the same thing at the hospital back in the day, as they say. And when I got home, both of my parents, and when I was 8 years old, they were just like, "This is yours. Have at it." So luckily they didn't have an A1C test then, which is what I joke with my endocrinologist now, because I'm like, if they did, who knows what the number would have been. but it sort of was a, neither my mom nor my dad has ever given me an injection. It was right out of the box, it's yours, and rock with it. And that was really kind of a struggle at the beginning, not really when you're 8 years old, what you're going to know. And then as we moved on through high school, but as it turns out, and as we'll talk about a little bit later, it's like those kind of things set you up for success later on in life, those type of struggles and that type of adversity. Also a little unusual is I didn't have an endocrinologist until I turned 18. So when I was diagnosed in 76, they didn't have, you look up in the phone book and I was 1 or 2. So I was just basically with my pediatrician until he threw me out. He was like, listen, you're 18 now, go forth and conquer. And that's when I got my first endocrinologist. And I had also heard it mentioned, or we were talking about last night, I've had 17 endocrinologists. And when I don't find one that likes to communicate with me or we can't work with, they're gone. To me, it's like shoes or a car. It's like, I don't like it, gotta go. You have to find what's right for you. During, like I said, when I was younger, I can't say for sure what my A1C was. I did play sports normally. I didn't meet another person with type 1 until I got to high school. And that was a big deal. And he's probably one of the most influential people in my life. And his name's Coach Ken Masor, and he was a track coach. And he was the first other person I met with type 1. So that was kind of interesting, and it really led to an understanding and allowed me to start to become more open about my diabetes as I understood it towards athletic events. The rest of the time was really just, up until that point, it was just winging it. And meeting him, he used to start every practice with a Tarzan, kind of dressed like Tarzan, which I won't do. But that was how I first met him on the first day. And in high school, I was the first athlete in New Jersey to get 4 years of 4 varsity letters. So I had 16 varsity letters before I got out of high school, and I had to get clearance from the New Jersey State Board of Education to double up sports. So I doubled up track and baseball. And there were some days where I would be a home track meet and a home baseball game, and I would do my sprint and then run over to my sprint event and then run over to the baseball field and play baseball for a couple of innings and then run back. Somebody come get me with the 200. And there was all these times when, I'd have my baseball jersey on, I'd be on the track. It was just a debacle. But during that time frame, the idea of how understanding diabetes and how its relationship is with sports really started to become more clear. And what's on the topic today is kind of the relationship between endurance sports and living with diabetes. And there's a lot of parallels. Playing a sport requires some of the things that Marty had spoken of earlier. Lots of education, lots of knowledge of your body, lots of knowledge of your sports, lots of training, lots of practice, lots of discipline. Those same things can be said for living with diabetes. You gotta have a little bit of discipline, some knowledge, situational awareness, flexibility, practice, and a little bit of discipline in dealing with the disease. It's how they coincide perfectly. And when I was playing sports in high school, it really opened the door to me to be like, hey, I have this disease and I have this condition and this is how it affects me on the field or on the track or on the baseball diamond. What can I do and what can I learn, which is what was mentioned earlier, about getting better at it? And as you learn, and I'm sure we have other people who are, we have world-class athletes in the room, they will tell you the things that you learn about diabetes, nutrition, and hydration, and all of those things will just be a benefit for you with, what you learn from diabetes will benefit you on the athletic field. And that was one of the reasons I was really interested in coming up and speaking, and I was so touched to be invited up, because this group is very unique. I've never spoken to a group that's as active and as focused. A lot of times, as was mentioned, we have a lot of groups for children and a lot of groups for older diagnosis, but this group is very unique in that you go hiking, you go skiing, you do stuff together, and that's really awesome. I couldn't wait to come up here and mention some of the things that I've been through. When I got out of high school, went to college, and true story, I was like, I'm going to play football. So I went to Rutgers University as a walk-on. You can tell, I'm 5 foot nothing. And I was like, I didn't get a scholarship, and I walked down there during the summer to try to make the team. And who's seen the movie Ruddy? All right. So I want you to watch Ruddy up until about 45 minutes to go, and just turn it off and throw it away. Because that was my football experience. Even the punter was like, this tall, and all I was doing was getting hurt. And I was like, this isn't for me. And I headed down, I left Rutgers, and I went to a small state school where the Division III, people were my size, and the coach actually left the country with the money. So they canceled the football program when I got there. And to this day, I still get calls saying, can you please donate to Stockton State College? And I'm like, no. I just can't do it. So in college, I kind of slacked off a little bit. I stopped. I still lifted weights, but I was so done with running. My coach was always like, run. I was in trouble a lot, so it was run a lot. And I didn't really do anything. Just kind of hung out. Lifting weights once in a while. And over those first couple of months, I really started to notice my health, not just my diabetes-related health, but my health in general, started to slide. Wasn't feeling good, clothes didn't fit. You notice, over that 2-year span, you really started to notice those things. And I was really thinking, it's like, I should do something again. I don't feel comfortable with myself. My diabetes is obviously out of control. The tools were getting a little bit better. And I rode past a sign of an old hair salon. I lived in New Jersey. They have hair salons, a whole bunch of them, just like you see on TV. And it was closed, and they opened a bike shop. And I was driving to school, and I turned around and went right in the parking lot, and I applied for a job so I could earn a bicycle. And that's how I got my very first official mountain bike back in the early 80s. And right out of the gate, it was one of those things, as you find a fit, and it's perfect. And on the little info packet, it says I have more bikes than I have dinner plates, and that's actually not true. That's actually true. You can call my wife after the meeting and ask her how many dinner plates we have, and she'll tell me we have more bikes. I love bicycles. Love them. Not like, oh yeah, bikes are cool. It's like, I love them. They're in every room in my house. It is the absolute driving force. It's the first thing I see when I wake up in the morning. I have 2 in my bedroom. There's a unicycle in the master bathroom, and I'm not kidding, because I don't know where else to put it. It's hanging on the roof. And finding that sport that I just could not get enough of was really the key to taking that final step towards understanding and getting better control of my diabetes. As time went on, I got the competitive bug, and I went and I did a 2-person 24-hour mountain bike race. One of my friends called, and he's like, guess what? And I was like, I don't know what. He's like, I just signed us up for a bike race. And I was like, great. I'm thinking half hour, 45 minutes, sun, and it'll be awesome. He's like, yeah, it's 24 hours. And I was like, 24 hours? What are you talking about? He's like, the race starts at noon on Saturday and goes to noon on Sunday, and you just ride around the clock. Isn't that cool? You hand off the baton. And I was like, yeah, actually, that does sound actually kind of interesting. And at the time, I was on a double Lantus dose, and I was still taking the old school regular insulin. So we're back in the day. They did have a blood glucose meter, but it took about 2.5 minutes to produce a number, which, if you think about it now, that's just ridiculous. And I went to this mountain bike race, and I was all gung-ho, right? I was like, yeah, we're going to do great. And I had never thought about decreasing insulin sensitivity, what to eat carbohydrate-wise, and it was a complete grease fire. It was horrible. I spent probably 15 of those hours hypoglycemic. Legit, and I mean in a bad way. Couldn't get enough carbs in, didn't know what to do. I took Lantus, right? So it's hanging around, it's not going away. I couldn't get rid of it. It's there for 24 hours, so it was just kind of, the whole weekend was kind of messed up. And it scared the bejesus out of me, just like we heard before. Some of those loads, are scary. And it's like I couldn't eat enough stuff. And of course, you're eating all this stuff, and it's time to go out and ride on a bike, and you have 6 pounds of sugar in your stomach to try to fight the lactus. And it's hard. We finished dead last by like 16 laps. I mean, it was, and he hasn't spoken to me since then. And on the way home in the car, I was looking out the window and I was upset because I had never had diabetes interfere that way in my life. It had always been get to track practice, play football, baseball. It was the first time that it actually stopped me from doing something. And there was a long ride home in the car, like 3 hours. And I remember this as clear as day. I was looking out the window, and there's support people that go with you, they hand you food and all that kind of stuff. And I didn't say a word, and we got almost all the way home. I remember turning around, and I remember saying to some of them in the car, I was like, I'm going to figure out how to do this solo. We're going to figure this out. Next race I'm doing is solo. And they were all, yeah, go ahead, here. So I started on this search to try to find out, what do I have to do to figure this out to go solo? And the endocrinologist I was with, she just shook her head, so I ended up leaving her. That was endocrinologist number 16. And I found a new guy down in UNC. I was talking to Dr. Adler earlier, and it's kind of about getting lucky. This guy was type 1 and a cyclist, and his CVD is type 1 and a marathon runner. So they were given a little thing at taking care of their diabetes session where they were pre-screening you, checking the speed and the blood pressure. And I stayed in this long line and I talked to him like, Joe, and he was like, I was like, you don't have to touch me, but I need to be your patient. And me and him kind of started working together, and the first thing we noticed was we started doing some research, and there wasn't any research out there about a type 1 athlete performing that long. It was like a blank page. So it was mentioned earlier, and it certainly was true for me. We immediately started with little tiny baby steps. It took about 18 months from the time I met Joe to that first 24-hour solo event. And we started with, hey, you're going to go ride for 2 hours today at this heart rate, this carbohydrate intake. This is going to be your recovery. This is your sleep pattern. And I recorded them all in a book. I have 3-ring binders I could cover this wall with of note paper from those days. Still have them. Lug them around with me everywhere I go. And I have an emotional attachment, so I actually can't really let them go. So if I have volunteers who want to scan those for me, there's probably like 10 or 20,000 pages that might take them on. And during that process, during that long process, the rides got longer, I switched to an insulin pump, we developed 10 basal patterns, we developed post-ride boluses, and we arrived at a solution that made it so we could go do this. And in August of 2007, I went down, I did my first 24-hour solo race at the Olympic mountain bike race course in Conyers, Georgia. And I ended up finishing top 10. Just in the, when I do things, I kind of go in the deep end pool. So I just immediately signed up for the expert class. Because, I figured it'd be better to say, I finished 26th in the expert class than to say I finished 3rd in the novice class. That's my positive thinking. And it worked. And from that, we took some of those notes and we started keeping them electronically, and the organization Type 1 Rider was born. And Type 1 Rider was nothing but a blank website with text on it. And the text was literally just notes I put out there about my training. And over the course of time, it was really interesting. Pretty soon, I got emails from other people from all over the place. Cyclists, triathlete in Europe. Hey, tell me about that 8-hour ride you did last week where you had the low. How did you treat that? How did you get back on the bike? How did you do some of those things? And the community kind of grew to where it is now. Jumping from 24-hour, the next big thing that we had heard about was this race called Tour de Bike. And anybody here familiar with Tour de Bike since it starts up here in Canada? Tour de Bike starts in a little town called Banff, which, everybody know Banff? The end of the Continental Divide Trail is at the Banff Springs Hotel in the backyard. There's a little sign there. And the bike race goes down the Continental Divide in the Rocky Mountains from Banff, Canada to the Mexico border. It's just short of 3,000 miles. And the key ingredient is it's completely self-supported. So it's not like you see on Tour de France, which is a hard race, where there's a team and a masseuse it's like you leave Banff with your tent and your pump supplies, and your insulin, and nobody can help you. So if you get a flat tire, you're on your own. You have a bike malfunction, you're on your own. You need to, you run out of water. I carry the filtration kit. You gotta find water. If you go hypoglycemic, you're on your own. There's so many self-service, about 3 to 5% of the route. And it runs through some of the most scenic places on Earth. And that challenged the same idea. And you're starting to see kind of a theme. It took 2 years of preparation to get to the point where me and my family, my endocrinologist, my cycling coach, were at a point where we're like, we can go try that. And it wasn't just 2 years of getting the physical ready. It was 2 years of, what do you do? You know, like, how do you treat hypoglycemia? How do you carry your insulin, your spare insulin? For carrying spare insulin, funny story, we actually took, the seat post of the bike, the seat attached to the seat post. We took the seat post out, we turned it upside down, and I built a revolver cartridge. And I took the insulin pen, and I took the insulin pens apart. And I took the little thin cartridge out, and I slid it into this little thing I made, and we slid them back up, and we screwed it into the bottom of the seat post. Those are the type of things we had to overcome to get through Tour de Line. It was the safest place to have it, and it was tiny. The way that we learned to carry some of the other devices, like the continuous blood glucose monitor, I happen to use a Dexcom, which is a little separate device. I have it Velcroed to the stem of my bicycle. It's like total guide the whole way. We learned how to carry how to strip down, how to field strip our diabetes supplies, and how to carry them in smaller, waterproof containers. These are some of the obstacles that had to get overcome. One of the best was I worked with a nutritionist who actually during this time, she got her master's degree by using me as her patient zero. We did a class, and this is great. If you ever get a chance, you should ask your nutritionist this. This guy was talking about this. I made her take me to convenience stores to figure out which junk food was the best to buy for athletic events. Because you go through towns where you might not have your choice of food. You might have Jim's gas station with, some Twinkies and whatever ring ding and some freeze-dried fruit. So those are the type of things that we had to learn and record and put together to kind of get through that event. I did that event twice. There's only been 250 people on the planet who've ever tried it, and only about 40% of them have completed it. So, all things on the table, I've actually never completed the race, and I'm okay with that. Being successful sometimes, as other athletes can probably measure, whether it's with diabetes or an athletic event, isn't necessarily winning. It's overcoming obstacles that are in front of you. So for me, the first year I did it, I had a very true near-life experience where I fell in the Spray River, which is, I don't know if you know what that is, it's in Banff National Forest, and I got swept down the river and I went drank. And I fell in the river because I ran into a grizzly bear. The second year, so the first year I was all just down, this was a failure, I didn't make it to Mexico, and the next year, the goals were small. The goals were have the courage to get up in the morning the day the race starts and meet Banff on your bicycle. And I won't lie, I was frightened. I was literally at the start line teary with fear because of the unsuccess the year before. Next goal was, hey, let's get past where we had the incident last year. Next goal was let's cross the U.S. border. Let's try that. Next goal was get through Montana. And so we were able to accomplish a bunch of those. But what's important is it's not so much about getting to that finish line, which is the goal of any true athlete. It really is. But the victories come in getting up in the morning tomorrow, testing your blood sugar, watching what you eat, and doing those type of things. Those are the true victories, because they carry you longer. You stand on the podium for a couple of seconds and you have war stories. But those things are what builds your constitution and make your life successful. We talk a lot about A1C, and my A1C right now is a 6.4, and that's usually about where it hovers. I am a very firm believer, I'll make sure there's no endocrinologist around me the looks because I might get one. There's no such thing as a good or bad blood sugar. I don't believe it. I don't believe that at all. It's a measure. I don't walk outside now and go, it's 52 degrees. That's a bad temperature. I go, it's 52 degrees. Maybe I should put a long sleeve shirt on and bring up a hat. The same for blood sugar. It's a measurement. Am I running higher than my target? Yes? Okay, I'm going to take a little insulin. Am I running lower than my target? Yeah, I need a little more food, maybe back at 10 days down, that kind of thing. And I believe the same for the A1C. You know, we hear people, and Chris and I were talking about earlier, we hear people are like, man, A1C, 5.3. Well, it's like, well, I mean, I guess for, you know what I'm saying, your mileage may vary. Your diabetes may vary. So what's good for one person, A1C-wise, isn't good for me, isn't good for anybody else. What are you trying to do? Live a long, successful life. For me, my A1C was down in the 5s at one time. And my endocrinology team and I sat down before Tour Divide and we're like, this is too low. There's not enough room for me, personally, for error. It's a measurement, right? It's a measurement. It's just a simple measurement of trending analysis of blood sugars over a period of time. That's important to remember. Don't let anybody ever hang a good or bad blood sugar on you. That just doesn't make sense. I also have a very unique perspective where I have 6 kids, which gives me a super unique perspective. Sort of like the Parker Family, that old TV show. Not quite agree. None of us can sing or play instruments. I have a stepson, who's type 1, who's now 8. He just turned 8. So we have some type 3s in the room, and my wife is very in tune with me and her son, and I'm the parent of a type 3 child. And I kind of know what that's like. And I seriously have to take a minute, and this is because I know how hard it is. If you care for someone who has type 1 and you don't have it yourself, you deserve the biggest hug and the biggest round of applause on the planet, because it's the hardest job on earth. You're acting as a pancreas. which, as we saw before, we don't even know what causes diabetes to get off. That's important. It's the same idea. You do the best you can. Don't let anybody hang a number on you or tell you, hey, this is bad or this is good. You have the hardest job on earth. And that's a fact. And I know this. We always tease with my wife because we live in 2 cities, probably about half the month. And she has a charity that we started together called the Blue Heel Society, which is safe for work. If you want to look up at work, it's safe. That's a joke. It deals with wearing blue shoes to advocate for diabetes. It's a very simple thing. Type 1 rider is all athletes riding bike across the continent, blah, blah, blah. This is very simple. You put on blue shoes, you go out. People are like, why are you wearing blue shoes? Sneakers, doesn't matter. She runs that out of Boston. I run Type 1 rider in my job down south, down in North Carolina, and we're apart. And I always like to tease her, or she actually teases me. We'll be on the phone. I might call her later tonight. And I'll be like, hey, babe, how you doing? She's like, good. How was your day? It's like, great. She's like, test your blood sugar. I'm like, okay. And sure enough, it's like 193, or it's 57. Do the math. It's 3.4, and we laugh. So you ever hear the diabetes alert dogs that they're selling now? She's my diabetes alert wife. That's what she calls herself. We have a little T-shirt made that says that. One of the important things about being an athlete and being an athlete is the ability to adapt to unforeseen situations. No matter what your sport is. You're running, you get dehydrated, you get a cramp, you have to adapt to that. You're rowing, something happens, you got to adapt to that. You're on your bike breaks, you get dropped out of lead pack, you have to adapt to that. The same for diabetes. It's very, very similar. Traveling up here, I was supposed to be here yesterday in Vancouver at 3 o'clock in the afternoon. I got here at 9 o'clock last night. There was a change in schedule. I was supposed to be on a plane at 6 o'clock in the morning. I didn't get on the plane until noon. Change in schedule. Those normal life events happen. Being successful with managing diabetes is having the knowledge and the tools and the ability to adapt to all those situations, no matter what they might be. On one of the races I did a while ago, I had a not a big crash, a minor crash, and it was a single 100-mile loop race. And I took a little bit of a spill and I broke my insulin delivery device. Gone, pump gone, not working. I had a syringe and one of those little tiny tubes out of the insulin pen with me. I simply switched to manual dosing of my basal rate. I hadn't practiced that. I just was like, what tools do I have left? This is what I got. This is how it works. Another thing that we all have access to if you're on an insulin pump, basal rates. I like to touch on basal rates just a little bit. I have more basal rates than you can shake a stick at. I have one called Nervous that I set a half hour before I talk. It's on right now. It's a 50% reduction of my normal rate. I have one for a normal race, one for a sprint race, one for a normal day, one for a business day. I have one for kids because my little boys will run my blood sugar into the ground. So like if I'm like, yeah, pick the kids up after school, I got a basal rate program for that. We learned through the athletic events how important those temporary basal rates are to success in your athletic endeavors, your hiking, skiing, whatever it might be. Your pancreas knows when it needs less insulin to be delivered. Your pump, unless you tell it to, not so much, right? It's like, hey, you got me on the standard rate, and I'm gonna rock it. For racing, my basal rate pattern, just for an example, for a 24-hour event, is an hour before the event, I set it down 50%. An hour before. Then 20 minutes before, I set it down to a 90% reduction, because I'm a nervous person, and the start of the race gets me all kind of wild. I know some people who bolus. You bolus for events, or you follow me? So I know some people who spike when they're nervous, so they actually bolus or temp basal the other way. 30 minutes in, I'm reaching my back pocket, I'm turning on a 65 to 80% reduction for the first 12 hours. For the next 12 hours, I drop that rate to an 80% to 100% reduction. Some of that based upon my carb intake and how I'm feeling and that kind of thing, what the event is and whatnot. And then about an hour before the race is over, I turn it off, turn the temp basal rate off, put my device away. And then as soon as I finish the race, I put my bike down and I bolus like a madman. Because I get a very steep kick right at the end. And I'll come off the bike and I tweet all my blood sugars real time, by the way. And there's probably about 13,000 of them out there. And I show the good, the bad, and the ugly because, there's all sorts of ranges. You'll see I'll be like, end of bike ride, 3.5 hours. PG is 67 Americans. And I'll take maybe 8 units of insulin. Everybody's like, man, my endocrinologist is like, you're kind of low, why are you bolusing? Well, we know there's a big spike that's coming later. And then that night when I go to bed, basal rate drops down again for an overnight for 6 hours, 25% reduction. I know, I'm coming. That's just an example of using the tools that are available and some of the things you learn over time with dealing with diabetes. I know I went a little bit deep with the technical stuff, but I just wanted to give kind of examples and stuff. If you have any questions, you can shoot them to me right now real quick. We have a minute or two or no?
We're going to be having the exercise facilitation topics if people have questions.
All right, cool. So if you have any questions, please let me know. Just grab me. Thank you for your time. Thank you for having me up here. I appreciate it.
So I'm going to address Dr. Adler. I'm so excited to have her here today. She is a psychologist and diabetes educator from New York, and she has had a complication-free life for 39 years, and she's actually the author of 2 books. So she's written one book about successful men who have type 1 diabetes. Tony has a chapter in that book, who you just heard from. And she's also written another book about successful women with type 1 diabetes, which Mari has a chapter. And I just want to let you know that she did bring 2 of the books, and they're part of the raffle draw. So a lucky winner in the audience will win one, and she will autograph the female book for a female winner. And there will be a male winner for the male book, and she will autograph that one as well. So without further ado, I would like to introduce Dr. Adler, who's going to talk to us about depression and diabetes, going from hopeless to hopeful. Thank you.
I'm gonna just speak them up here. Or less. Is this? How do you put that in? 30 minutes.
You can talk less if you need to.
I don't want to talk less. I have more.
30 minutes, please.
Thank you all very much for your warm welcome, and I'm very happy to be here. I also had a long trip to get here. I have to say that I am very emotional when I speak, and that's just my style. So I have a lot of nerves, and you'll see them. So I'm very happy to have also heard Mari's story and Tony's story because, as Ramya said, they're both contributing writers in my books, and for me this was a real treat to get to meet both of them. I wasn't going to talk so much about myself because that's not really my topic, but just so everybody understands that I have also type 1 diabetes. I have it for 39 years. I hate to tell you what age I was if I tell you how many years I've had it, because then everybody has to take off their fingers, their shoes, fingers, count on your fingers and toes, and I really hate to do both of those, but if you promise not to try to do the math. I was diagnosed when I was 20, and I have it 39 years, and in my story in the book as well, I talk about all the dark ages of diabetes, and you have so much more opportunities now with technology that, they're really, I really hope that nobody is feeling so depressed about living with diabetes. I'm going to say diagnosis before 1921, 22, when they discovered insulin, that was a very hopeless time. And then people, the technology has improved over time, and I really, I think that people who are diagnosed now or more recently in the recent past, you have so many options available, and your future looks bright. So I'll tell this story. I feel my emotions coming. Okay, so when I was diagnosed, I actually I had all the typical symptoms of being, excessively thirsty, running to the bathroom, no energy. Those are typical, okay. And I lost a lot of weight. I knew something was wrong, but I didn't think it was anything particularly serious. I knew that I had no energy. I'd walk on campus at college, and I would literally think, the world is passing me by. People walked by so much faster than I was, and every single classroom went to, by way of every water fountain on the campus. And I was so thirsty. I remember thinking to myself, I could drink the ocean and I just would never quench my thirst. I knew something was wrong, but I really didn't pursue anything. Okay, at the same time, my sister had to go to the doctor because she had some medical forms that needed to be filled out. And so what happened was my parents brought me along to the doctor, and then they ambushed me. And they said to the doctor, we're actually very worried about our other daughter, me, because she's lost the sparkle in her eyes. What? What? I was like, what are you talking about? I had no idea. But I mean, I really didn't, I didn't really know, but clearly they had seen something. And the doctor's attention turned from my sister to me, and I was like, I'm not your patient, you know, she is. And I think already he had quite a clue of what was wrong, and he put me through some tests. And okay, so here's what happened. My mother was a professor at the time, and she had a student who was ill in her classes and had gone through tests. And so what happened was the doctor told me at the end of that week, the diagnosis was I had, at the time they called it, juvenile diabetes. Okay? My mother's student was diagnosed with a brain tumor. Immediately, I said, I can live with this. I had no problem whatsoever. I was not depressed being diabetic because I could live with it. And I don't know what happened to my mother's student, but I'm sure it was not a good ending. And so to say everybody's reaction to being diagnosed with diabetes can be different, and there are many who are in denial and they don't want to think anything about it, and there are plenty of people who are depressed because they worry about the future, but I think your future is much brighter with all the new technology. And my brother had a very unusual reaction when I was diagnosed, and he said to me, "Congratulations." And that was the most unusual that I've ever had. And I was like, "Why are you congratulating me?" And he said, "Because I know you'll always take good care of yourself." I'm sorry. So, it is not a hopeless story. I will say, when we talk about diabetes and depression, you'll hear a lot about that. They are very linked, diabetes and depression. You have twice as likely the chance of having depression. And they don't make the distinction between type 1s and type 2s when they come out with that statistic. So depression is a very serious issue. Okay, I put up on this slide the symptoms of clinical depression, and I wouldn't want anybody to really ignore these symptoms because, you know, I don't want anybody to harm themselves. So typical symptoms of clinical depression are difficulty concentrating, feeling exhausted and lack of energy, feeling guilt or worthlessness, helplessness, hopelessness, pessimism, insomnia, sleep difficulties, okay, irritability, restlessness, I'm going down the list, loss of interest in activities or hobbies, once pleasurable, including sex, overeating or appetite loss, persistent aches or pains, headaches, cramps, or digestive problems that do not seem to ease even with treatment, persistent sad, anxious, or empty feelings, and then thoughts of suicide and suicide attempts. And so that's a pretty big list of symptoms of clinical depression. But I will say some of them also look a little bit like symptoms that are associated with diabetes. Okay, and I think that sometimes depression, oops, okay, I pressed that by accident. There we are. Okay, so I think that sometimes, depression, I don't want to give a short shrift to, you know, depression because it is important, but some of these things are also similar to having diabetes. So you can have lack of energy if your blood sugars, let's say, are too high or too low. You can feel sometimes helpless with your blood sugars. You can feel irritable with your blood sugars. I mean, a lot of these symptoms, there's a little bit of overlap. And I think sometimes there's too much pathology given to diabetes symptoms and calling them depression, and they may not be depression. So I'm going to give you an example. Okay, this says, for my next trick, I will simultaneously carry on a conversation, count the carbs on my plate, test my blood glucose, and give myself insulin. Okay, now, this has a different name than depression, okay? And this is a new concept that Dr. Bill Polanski, who's in San Diego, he talks about this. He came up with this wonderful idea, and I'm the one who keeps talking about it because I think it's really important for all of us to hear about rather than depression, okay? Depression is something, if need be, you treat with medication, antidepressants, okay? So now what I'm talking about is not called depression. It's called diabetes-specific distress, okay? And that's what I think anybody who's here who has type 1 will feel that distress. It's a stress. So what is diabetes-specific distress? It's the emotional distress that arises from living with diabetes. It's very stressful. We have to try to keep everything in balance. It's not an easy job, and you know, it's our responsibility. And diabetes distress is associated with diabetes self-management and blood sugar control, which is not the same cause of clinical depression. Okay, clinical depression, not to minimize that again, but clinical depression can have more to do with an imbalance of your, chemical imbalance in your brain, your neurotransmitters. You can get medications for that. This is not that. This is, it's divided into 4 different aspects, okay, diabetes-specific distress. The emotional burden, okay, of living with diabetes. So there's feelings of shock and denial and sadness. Certainly when you're initially diagnosed, you can be feeling angry, you can feel frustrated, you can feel guilty, for lots of reasons, you know, good and bad blood sugars, like what Tony was saying. You know what, there's a lot of ways that people can stress you and you can stress yourself. Feeling like a failure if you're struggling and having a hard time, and anxiety, lots of anxiety going on with the future and complications. Then there's the physician-related distress. So Tony went through 17 endocrinologists. That's called stress. You know, you're not confident in your doctor's competence, or you have a difficult relationship with your healthcare providers, or you feel that your doctor is critical or judgmental of your self-care. I have lots of patients who tell me, I don't want to talk to my doctor. My doctor's going to yell at me. And I'm like, find a different doctor, because that's not the answer. Okay? Doctors yelling at you is not going to help motivate you one bit, and it's contributing to diabetes-specific distress. Okay, regimen-related distress. Okay, trying to, watch your diet, watch your exercise. All these things are important for our good control, but they're also stressful, finding the right balance, okay? Monitoring your blood sugar and taking your insulin. There's a lot of questions that go with all of those choices. How much of this, how little of that, what timing, all of that. It's all stress. It's all stress. Regimen-related distress is the third component of this diabetes-specific distress. And then the last part is interpersonal distress, okay? I know we don't have any type 3s here who are ever stressing out their type 1 family member or loved one, but there are a few, type 3s out there who do have conflict and related to diabetes issues, and it adds to our distress. And not receiving emotional support from family and friends is a stressor. Okay, so Okay, now I'm going to talk a little bit more about diabetes-specific distress. Okay, the symptoms. So Dr. Polonsky actually made up a test up for measuring, it's a subjective test, for measuring diabetes distress. So he has these 4 subscales, which I just talked about: emotional burden, physician-related distress, regimen-related distress, interpersonal distress. So as an example of emotional burden, okay, feeling overwhelmed by the demands of living with diabetes. I don't even think we need the other 3, but you know, it is very stressful, okay? And it can look like depression when you're frustrated, when you need your diabetes break, you know, and we don't really get a break. It's 24/7. I see patients all the time because I tell them diabetes doesn't take a vacation. And so it can look like depression to somebody who's not familiar enough with what we deal with as dealing with the stress, okay? Physician-related distress. So an example would be feeling that my doctor doesn't give me clear enough directions on how to manage my diabetes. Okay, so some doctors are very cookie cutter, and they don't really cater to your individual circumstance, and they may just give you instructions, and they don't modify it. So regimen-related distress, not feeling motivated to keep up with your diabetes self-management. I think motivation comes in when you're struggling and not having the results that you want, and some people just give up, which is not the answer, but it's understandable, and you need to find somebody who will understand and help you so that you can modify the regimen so you don't have to feel the distress related with it. And then the last, interpersonal distress, an example would be feeling that friends or family are not supportive enough of self-care, such as planning activities that conflict with your schedule or encouraging you to eat high-carb foods. Okay, so that's, you know, and we get a lot of that, you know, oh, come on, it won't kill you, you know, or, you know, and it's very, very difficult. There's also, that's the diabetes police, that part of the interpersonal distress, if you've heard of that expression, also coined by William Polonsky. And you can get either of those 2 extremes. So you can get the diabetes police that says, wait a minute, what are you eating? You know, how many carbs, and did you bolus for that, and what's your number, and okay. So that I would call not helpful and leading to stress, or the opposite of, oh, come on, you can eat. It's just a little cake, you know, go ahead. But I made it specially for you. I mean, okay, you all know what I'm talking about. So, okay. So this is actually a slide that I got from Twitter. And Tony, by the way, I follow you on your blood glucose all the time. And I love that you tweet it good, bad, and ugly. You know, I mean, I think it's honestly, I think you're very brave. I'm not sure I'd want to tweet out all my numbers, but so here's on the left side, non-diabetic thoughts, okay? And it says, I wonder if there's anything good on TV tonight. I should make plans for the weekend. There's a little part of the brain there for sex, a little part for food, a little part for family and friends, a little part for school and work, money, hobbies, thoughts like, what should I make for dinner? I hate being stuck in traffic. I really should go to the gym today. So those are all non-diabetic thoughts. So the right side are type 1 diabetic thoughts. Do I have enough snacks with me? Did I give enough insulin for that? Why won't I bleed? What is my blood sugar right now? Okay, and everything, all those thoughts are pain tolerance, ketones, food, health insurance, the next A1C, carb counting, and then the tiniest little part there is what everything that a non-diabetic thinks about. So we are stressed to the hilt, okay? That is an example of diabetes-specific distress. That's where our brains are. So, so now we get to the hopeful part of the presentation. So what can you do with dealing with your diabetes-specific distress? And the answer to that is cognitive behavioral therapy, which is the type of therapy that I teach my patients, okay? Cognitive behavioral therapy is about looking at your situation, diabetic or non-diabetic, looking at your situation at events which you cannot change, okay? So it's raining out. We can't change that. So now, how you think about that event that you cannot change affects how you will be feeling about it, okay? So if you have the thought, this is terrible weather, I really hate being out in this rain, it does zzz to my hair, whatever you're thinking, you're going to feel depressed. It's raining. However, if you take a different thought and you go, oh, it's raining again, I'm going to bring my umbrella, I'm just going to, I'm going to have my boots, I'm going to be ready, I'll do a little stomping in the puddles, and it'll be singing in the rain. And it doesn't have to be a terrible thing. You could at least be prepared for it. If you can't be thrilled with it, at least be prepared and make it more neutral. So how you think about something, which is an event you cannot change, how you think about it affects how you will feel about it. And if you have very unreasonable thoughts, like I hate this and this is a pain in the neck, you're going to feel very negative. And if you think differently and say, all right, I'm not thrilled with this, but I can deal with it, you're not going to be so depressed or anxious or guilty or irritable or whatever negative emotion you're feeling. So, okay, so one of the types of unreasonable thinking is called all or nothing thinking. Okay, and that can cause feelings of emotional burden. Okay, when you see things in black and white categories without shades of gray, if your performance falls short of perfect, you see yourself as a total failure, and that is unreasonable. Okay, I mean it's just unreasonable. Why is that unreasonable? Because nobody is perfect, for one thing. Okay, so if you have the thought, I need to keep my blood sugars perfect, that is unreasonable. And that will only make you feel miserable about yourself and very angry, upset, depressed, whatever you want, okay? And then if you can use cognitive behavioral therapy, change your thought. We can't change, certain events, okay? But if you change your thoughts, like we have to check our blood sugars, you can change it to, I will do the best I can to keep my blood sugars within my target range and feel good about successful control. You're not going to, and even if it's not perfect, you're not going to feel depressed or negative or whatever, okay? So, okay, here's another example of thinking that is not helpful. It's the fortune teller error. Okay, it can cause feelings of physician-related distress. When you anticipate that things will turn out badly, fortune teller, and you feel convinced that your predictions are an already established fact. Okay, so your unreasonable belief is, my doctor doesn't give me clear enough directions to manage my diabetes. So now using a more reasonable approach, you can say, I will wait and see what directions my doctor recommends, and if they are not clear enough, then I will assertively ask him to repeat it until I do understand them. And you can change that fortune teller error by not predicting ahead and then by being assertive and get what you need without feeling upset. Okay? So, These are also, this is related to regimen-related distress. This is not an exhaustive list. I actually have more, but I'll just go through the ones that I brought. Okay, so must statements can cause feelings of regimen-related distress. When you motivate yourself with musts, the emotional consequence is guilt. Okay, so you have to challenge this unreasonable belief. I must exercise for 1 hour every day or else I'm a bad person with diabetes. The idea of exercising is a good one, but if you don't have the chance, it doesn't make you a bad person. So you have to challenge that with a more reasonable belief. I will try to make time to exercise every day. I will do the best that I can and be proud of what I can do. If you have that attitude, you are going to feel so much better about yourself, okay? As opposed to feeling miserable if you don't fulfill the must statement that you've made in your head. And then interpersonal distress, okay? These are should statements. Should statements are things that when you direct should and shouldn't statements toward others, and then you'll feel angry or frustrated or resentful. Okay, so an unreasonable belief would be, my family should not eat ice cream in front of me. I feel angry that I can't have any. I literally hear these stories all the time, and it's just, it makes people so angry and upset, and it's so unreasonable. So let's change that to a more reasonable belief. My family can eat ice cream in front of me. They have a right to eat and enjoy. I don't have to feel angry because I can choose to eat a little also. Okay, and self-deprivation leads to a lot of resentment, and I'm not going to, endorse anything where you build up resentment. Okay, so, how am I doing? Okay, 10 minutes. Okay, so I have other coping strategies. And this is not necessarily cognitive behavioral, but they're in general, okay? So in order not to feel so depressed or feel so distressed with your diabetes-specific stressors, one of the things you can do is validate the normalcy of your feelings of being overwhelmed and burned out. Okay, so diabetes is, it's a hard job. No one asked for this job. We have it 24/7, and it's normal to react with, frustration at all of that you have. And you can feel burned out. But, so if you are feeling negative, of course, I want you to challenge those beliefs that are causing it, but if you are feeling negative, just accept that, yes, it's okay to feel negative, okay? We're not, nobody is thrilled to have diabetes. Nobody goes, woohoo, take a diabetes, but, it's not a death sentence, and so, you can feel badly that you have to deal with it, but, when you look at, somebody who has a brain tumor, I didn't feel so badly anymore that I had diabetes. So you can talk to a healthcare provider about diabetes distress. Okay, so sometimes you can take antidepressant medication. I am not a big fan, and I'm not promoting antidepressant medication for diabetes-specific distress because it's not a chemical imbalance. But if somebody feels that they need that temporarily, I certainly would not deny them, but I'm going to say that would not be my first strategy to deal with your feelings of depression. So, talking to family members, friends, or others with diabetes to express your feelings. Well, guess what? Having a type 1 and young group, young and type 1, I think this is great, because here's a place where you have kindred souls. This is a place where you can talk and everybody says, I have that problem too. Okay, and then you don't feel so crazy, and I'm going to say, when I was diagnosed in 1975, I did not know a single person who had diabetes at all, and I went for, I'm going to say, probably more than a decade before I ever met a person with diabetes. And I do remember my excitement once running in a ladies' room where I was taking my insulin with the syringe and the vial, and there was another lady doing the same thing, and I was so excited. And I mean, that's a long time to, 10, 20 years, and I never ran into another person with diabetes. I just felt so thrilled to meet her, and it was just a passing, but this is what is so helpful. Social media is so helpful. You are not alone at all, and that's a big issue, so that you don't feel like you're the only one and no one understands, and that can lead to a lot of distress. And my books also. I mean, I wrote my books. The stories in the books, the women's book has 24 stories, which I'm the first, and Mari's in my book. And they're all wonderful stories, and they're uplifting stories, and there's a similarity in all of them about having to accept having your diabetes and then what you do with it, okay? And what you do with your life living with diabetes. And not in spite of the diabetes, but sometimes because of your diabetes, great things could be accomplished. And the books are also very spiritual in that I talk about diabetes as a blessing in disguise. That's a very hard concept for some people who are especially angry at their diabetes to understand, because if it weren't for diabetes, I agree with my brother, I may not have taken such good care of myself. And diabetes is a blessing for me. I eat healthy, I live healthy. It became my career focus. I became I was going to be a psychologist, but that became my focus of my practice. And, I'm happy to have diabetes. I feel I can live with this. And, so the books, both books have the same appreciation of diabetes is a blessing in disguise. And my men's book is 25 chapters, of which Tony is one of my chapters. And also, just across the board, they're not, I have to make one correction, they're not only type 1s, okay? They are type 1s, type 1.5, and type 2s. And they're across the country. I have one Canadian in my men's book, and I was criticized for that in my women's book, that I didn't have any Canadians, but the men's book has one. And so they are all different ages that they were diagnosed, and all different ages in the book and how many years they've had it. And the oldest one in my women's book, she had diabetes for 70 years. And she really was around in the dark ages. And she managed, and hers is a real story of triumph. And in my men's book, the one who had it the longest is, at the time of the writing, he had diabetes for 63 years. So, I think stories like that really help to inspire us, me too, even with my 39 years. I mean, I look ahead to these people and see the future, that it doesn't have to be depressing. Okay, so changing one thing at a time is important if you want to try to manage diabetes distress by changing one thing at a time in your life, so that whatever is the most distressing thing, you're going to start with that. You can't change everything at once, because then you can't, it's just too much change. Okay, more coping strategies. So make changes slowly, okay, so that they become more natural into your routine. Behavior change works best when not done alone. Focus on behavioral goals, okay? So instead of just saying you want to lose weight, you would say focus on how many carbs you want to eat, okay, very behavioral. Focus on the amount of time you want to exercise. Focus on items, goals that you can specifically measure rather than these vague terms, because it's hard to measure success with a vague term. And so I have it as the last, but it's really the most important, is taking responsibility for diabetes management is up to you. Okay, the person who has diabetes. This fact can be either overwhelming or empowering. And acknowledging full well that this is a tough job. And it can be empowering by motivating you to be proactive in your diabetes management. People who are engaged in their own self-care are less frustrated, more upbeat about having diabetes. Empowerment can lead to good diabetes self-management, and you can control your diabetes and not let diabetes control you. Those are all really, really important concepts. And so before I close, I'm going to say that one last coping strategy, one positive coping strategy, is the use of humor. So my last slide says, laughter is the best medicine. Well, unless you're diabetic, then insulin is probably better. So I thank you for all your attention.